Next, we'll talk about medications that affect the cardiovascular system. The first section is entitled Antiarrhythmics. In this section, we'll discuss antiarrhythmic medications. In this section on antiarrhythmics, we will discuss a basic set of commonly used medications. Antiarrhythmics are classified according to class 1 through 4 nomenclature. This system is outdated, however, it's still a useful framework because it helps to remember which method the chemical uses to prevent arrhythmias in the heart. Antiarrhythmics are classified based on the type of channel that they block or the receptor that they block. For example, class 1 antiarrhythmics are all sodium channel blockers. Class 1A work by increasing action potential duration. Class B actually shorten action potential duration but increase the refractory period. Class C decrease conductivity but do not have an effect on the action potential duration in general. Therefore, class 1A, 1B, and 1C are all different in their ability to prevent and stop arrhythmias. Class 2 medications are beta blockers. Class 3 medications are potassium channel blockers. And class 4 medications are calcium channel blockers. Some medications can actually fall under more than one category. Here we see some examples of different antiarrhythmic medications. Class 1A, we see quinidine and procainamide. Class 1B, we see lidocaine. Class 1C, flecainide. Class 2, we see beta blockers. Class 3, we see amiodarone and sotalol. Class 4, verapamil and diltiazem. And some unclassified antiarrhythmics include digoxin and adenosine. Let's talk about class 1 antiarrhythmics. These are the sodium channel blockers. These work by blocking fast sodium channels that are responsible for the early depolarization phase of the cardiac action potential. Again, these cause use-dependent block. These block either the open or the inactivated state of the ion channel, but not the closed state or the relaxed state. These block high-frequency excitation of the myocardium but allow for normal cardiac function. Here we see the cardiac myocyte action potential on the bottom of the graph and then the associated EKG. What we see here is that during phase 4, we have a slow depolarization that occurs. There's a slow upward slope here. During phase 0, we see a rapid upstroke. Phase 1, we see a downstroke. Phase 2, we see sort of a plateauing. And phase 3 is a rapid repolarization. And then we go back to phase 4. Different antiarrhythmics work on different components of the cardiac myocyte action potential. We see here that the QRS complex, which is representative of ventricular depolarization, occurs during the depolarization phase, whereas the T wave, which is responsible for repolarization, occurs during repolarization on the cardiac action potential. Class 1A medications, the classic medications are quinidine and procainamide. These block open and inactive state of sodium channels. Remember that fully repolarized channels or the relaxed channels do not bind the drug well. Quinidine works by blocking sodium and potassium channels. It is orally effective and is usually not given anymore except for some ventricular arrhythmias. We have medications that work better than quinidine. It's become sort of outdated at this time. The adverse effects of quinidine are classic in that they cause synchronism, which has the following side effects: nausea, vomiting, tinnitus, ocular dysfunction, prolonged QRS, and QT prolongation as well. Quinidine and digoxin have a classic drug-drug interaction in that quinidine decreases the renal clearance of digoxin, which increases the concentration of digoxin, which can increase its toxicity. Procainamide is another class 1A antiarrhythmic. It is orally effective as well, and is still being used today. It is metabolized by N-acetyltransferase to NAPA. N-acetyltransferase, again, shows pharmacologic variation from person to person. There are some patients that are fast acetylators and some are slow acetylators and have different activities of this enzyme. Procainamide is used only infrequently except for some ventricular arrhythmias. Some classic adverse effects of procainamide include a lupus-like syndrome that can occur in patients that are taking it. Procainamide can also cause torsades, Again, slow acetylators are more likely to have these adverse effects. The classic 1B medication is lidocaine. Lidocaine is still given. It's administered intravenously for many types of arrhythmias, especially following myocardial infarction. It's also used during open heart surgery. Remember, this is also a local anesthetic. This medication, lidocaine, works very well in ischemic or abnormal cardiac cells. The clearance of lidocaine depends on liver blood flow. It has a rapid first-pass metabolism, therefore it cannot be given orally. It has to be given intravenously or parenterally. Lidocaine can actually cause seizures if it's accidentally injected into an artery or if it's given in severe overdose. Class 1C medications are not given as much anymore. These include flecainide and encainide. Again, these have a limited use because of a trial called the CAST trial. In this study, patients that were taking flecainide and encainide showed an excess mortality following a myocardial infarction. Class 2 antiarrhythmics are beta blockers. These are commonly used following myocardial infarctions to prevent VTAC and VFib. These are also used for supraventricular tachyarrhythmias, such as atrial fibrillation. Esmolol is the classic beta blocker that is given for arrhythmias because it's able to be titrated quickly on and quickly off in an intravenous form. It has a very short half-life. Class 3 antiarrhythmics are potassium channel blockers. Amiodarone is the prototype. Sotalol is another class 3 antiarrhythmic that is sometimes used for ventricular arrhythmias. It can be used to suppress the ventricular ectopic beat that may be causing ventricular tachycardia. Remember that sotalol is also a beta blocker, but because of its class 3 properties, we classify it as a class 3 potassium channel blocker. Amiodarone is used effectively for a wide range of both atrial and ventricular arrhythmias. Amiodarone was unpopular approximately 10 years ago. However, it became more popular when it was shown that amiodarone works quite well and that its side effects are very minimal when this medication is not given for a long period of time. Patients that have Wolff-Parkinson-White syndrome or an aberrant pathway should not take beta blockers or calcium channel blockers for certain arrhythmias. Instead, amiodarone has been shown to be very effective and safe for these patients. Amio has a very long half-life, almost 30 to 60 days. Therefore, it needs to be given as a loading dose and then maintenance for a long period of time in order to be effective. It also decreases the clearance of many other medications such as digoxin, warfarin. The classic adverse effects of amiodarone should be memorized for step 1. They include blue-gray skin pigmentation, pulmonary fibrosis, corneal deposits, lung QT, and they can actually cause hypo or hyperthyroidism. Here we see a patient that's been taking amiodarone. The sun-exposed areas of his face have developed a bluish tint. And as you can see, the drug amiodarone has a nucleus that has a benzene ring with 2 iodine molecules attached that resembles thyroid hormone. Class 4 are the calcium channel blockers. The prototype molecule is verapamil. Today, as an antiarrhythmic, the most commonly given medication is actually diltiazem. These medications work by blocking the L-type calcium channels. Nifedipine is not used for arrhythmias because it lowers blood pressure to a very large degree. So the most commonly given calcium channel blockers for arrhythmias are verapamil and diltiazem. These medications are used in prophylaxis for certain types of arrhythmias, including reentrant, nodal, and atrial tachycardias. Again, these are contraindicated in patients with WPW because a calcium channel blocker may promote the abnormal conducting pathway instead of using the AV node. Again, calcium channel blockers can have multiple side effects, including dizziness, flushing, hypotension, and constipation. Adenosine is another antiarrhythmic that's not classified according to the 1, 2, 3, 4 system. Adenosine activates G-protein-coupled receptors, which can affect potassium and calcium channels. Adenosine is the drug of choice for supraventricular tachycardias, especially paroxysmal supraventricular tachycardias. This medication is given intravenously, and it's very quick. The half-life is 30 seconds, so it needs to be pushed very quickly. It causes a sensation of burning in the chest as it's given. Patients that are having a supraventricular arrhythmia and they receive adenosine, their heart will actually briefly stop for approximately 1 to 2 seconds and then usually resumes in the sinus rhythm. Digoxin is another antiarrhythmic that's not classified according to the 1, 2, 3, 4 system. Dig is used for two different types of patients. It's used for patients with heart failure and those with rapid atrial fibrillation. The way that it works for heart failure is that it inhibits the sodium-potassium ATPase, which leads to an increased concentration of calcium inside cardiac myocytes. This causes increased inotropy and allows the heart to beat more strongly. For patients with atrial fibrillation, the way that it works is it decreases AV nodal conduction. And what this does is that it takes the rapid atrial fibrillation that's occurring and it makes it into a slower ventricular beat by not allowing all of the atrial fibrillations to pass through the AV node. It does this through some type of intrinsic parasympathetomimetic activity. We'll talk more about digoxin in a later lecture. This concludes our section on antiarrhythmic medications. Our next section will deal with antihypertensive medications.